So, what is the number needed to treat to see efficacy of magnesium in venous disease? Because you are giving magnesium for 2 years, 3 years, and to reduce the episodes of this vertigo. So how long you want to give to see
all of these patients, if you don't drug, they have very frequent attacks. It is not about they will in the early courses of their lifetime. The attack duration might be more than 1 year or 2 years, but as soon if once they cross 5-7 years of disease process, this comes down to 2 months, 3 months, and sometimes patients are coming to us 1 month, every month they are having attacks.
You mean to say this isolated magnesium supplementation addition is going to help patients with venous disease?
What we can give is we will avoid diuretics because these drugs already have some drugs that have potassium losses from the body. So magnesium is a drug which we can easily give with no side effects for long. Ultimately, they will have attacks. That is 200 milligrams per day.
Is this elemental or is it basic?
It is elemental. It comes out magnesium sulfate, 200 milligrams.
So, how many of you think that doctors are the worst patients? Okay. So, I will tell you just one story. It will take just 1 minute. So, I had a venous patient who was a SR in surgery department. So, we gave him weekly once diuretic. So, one fine Friday evening, he called me, boss, this is a diuretic, no? Yes, it is diuretic. Boss, can I substitute it with some whiskey? Because it is also diuretic. मैंने बोला भाई इतना नहीं तुझे पीना है पी ले, but it should not be done. So next topic is acute unilateral vestibulopathy by Dr. Harshita.
Good afternoon, everyone. After all the lectures by Srinivas sir, Rajat sir, and everyone, I know you guys have been fully charged, but beg me pardon if something I go wrong or fumble, because I'm just a little person trying to explain few things which I know from my side. So today we'll be talking about acute unilateral vestibulopathy, which is short formed as AUVP. It was nomenclatured in 1996 by Faber, but we use this word synonymously over the decades with vestibular neuritis, and all. So acute peripheral syndrome with no evidence of neurological and audiological signs and symptoms. So I've already told we use this word synonymously with vestibular neuritis. Most common pathogenesis is because of the inflammation of the vestibular nerves, which is believed to be caused by latent reactivation of the herpes simplex virus in vestibular ganglion. But recently paper has been shared that it could be because of any kind of infection. Now, one paper has been shared by Ajay Vats sir, it's because of a rickettsial infection also. So there are n number of causes, most commonly believed to be as inflammation. Now, we have two group of nerves, that is superior vestibular nerve and inferior vestibular nerve. Superior vestibular nerve being affected the most. Why? Because it has a long course, so the inflammation affected area is more, and because of the long course, the canal has bony spicules, so it is pressing. So, categorized into 3 types: superior AUVP, inferior AUVP, and total AUVP. Total AUVP is the rarest, but it has been reported in few cases. Now, according to the Bellamy Society, it has been classified, diagnostic criteria has been classified into 4 categories: AUVP in evolution, probable cause, and history of acute unilateral vestibulopathy. I'll just describe the standard ones, and then following the subsequent categories, I'll be just mentioning what is the change from the basic one. So, acute onset of sustained spinning vertigo of moderate to severe intensity, symptoms lasting for more than at least of 24 hours. So, moderate when patient is able to perform his baseline activities, walking, going to the bathroom. But severe, the patient is so debilitated that he is unable to get up from the bed. So it has to be at least for 24 hours. Spontaneous vestibular nystagmus with a trajectory appropriate to the semicircular canal involved. So most common we talked about is being superior vestibular nerve. So horizontal and torsional component. Why? Because semicircular superior vestibular nerve supplies horizontal canal and superior canal. Third, unambiguous evidence of reduced vestibular ocular reflex function and on the side opposite to the fast phase of nystagmus. I'll just explain this point in the coming graphs and the videos. No evidence of acute, central or audiological symptoms. One point tells about the symptoms and other tells about the signs. So consecutively point is no acute neurological signs and otological or audiological signs. Last one is common for everything, not better documented by any other disease. The next one is in evolution. So in evolution we just word when we think of evolution comes into the mind duration. So in this category, duration of the vertigo only changes. So continuous symptoms for more than 3 hours, but it hasn't reached to the duration of 24 hours. Then third, probable, we are thinking because the reduced VOR deficit is not clearly visible or documented. History of acute or subacute onset of vertigo lasting at least 24 hours and slowly decreasing in intensity. Unambiguous evidence of unilaterally reduced VOR supports diagnosis after acute phase. This is the stage when most of the patients visit us. Because in acute stage, the patient is so debilitated that he is not able to get up from the bed. Once naturally the procedure of healing starts, after giving anti-vertigo drugs, then patient comes to us to seek help. Then symptoms. Spinning or non-spinning vertigo, head motion intolerance. Head motion intolerance signifies when patient is moving head in any of the direction. While he is moving, he feels so much of giddiness that it becomes intolerant and he will take a position which is most comfortable to him in the sense. Vertigo he is feeling in every position, but he will acquire a position where symptoms are minimum. So his brain thinks, I feel much better in this position. Oxylopsia, postural imbalance, nausea and vomiting. Few patients, while giving the history in the OPD, says they had few episodes of vertigo. I beg your pardon, this should be within 24 hours before the sustained vertigo. Then signs. We'll be discussing more about the signs because these are the most important factors which we need to have, which help us to diagnose a patient with AUVP. Horizontal or torsional nystagmus, because superior canal is involved, superior vestibular nerve is involved. Then nystagmus towards the unaffected ear. After Sir's lecture, I don't need to explain this. Intensity reduced by fixation, direction fixed, obeys Alexander's law, and other nystagmus type, that is vertical torsional in inferior, and in rare cases when total AUVP is present, pure horizontal, because it cancels out the vertical components. So this is my patient, and my videos have been shared with Dr. Prateek as we share the same OPD, so our videos may overlap. So for that, please forgive us. So he was the one who was visiting our OPD 2 years back. So I'm showing a head impulse test on him. See, when head impulse is done in left side, it was nothing. But when right side it is produced, there is a slight delay in the eye. See, this part.
Right.
See, the left side there is no delay, but right side there is slight delay. You will see over here. When you focus on the left eye. Then this patient, this is my first case of vestibular neuritis in Hardoi. So he was the one, he's 70-year-old male. The acute irritative phase of vestibular neuritis has passed on. He was feeling giddy and then he reported me. He was 17 years old with a history of hearing loss which was preceding it. When he showed up to my OPD, while sitting, spontaneous nystagmus was observed. See, it's a left beating horizontal nystagmus. Can you all appreciate it? by now we should know if it's a left beating horizontal nystagmus, so the right side is affected. So it's a case of right vestibular neuritis. So now these are the VNG findings. What happens to the nystagmus? So nystagmus in light. So it's a left beating. You can see in both the eyes, right eye and the left eye, it's left beating in light. Now, the intensity is increased in both right and left eye once the fixation is removed, spontaneous in dark. So this suggests of a peripheral disease, more of a peripheral disease. Intensity over here has increased. Then it follows Alexander's law. There should be a horizontal nystagmus in dark, left side. I am considering the case of right vestibular neuritis. Yes, sir, please. This one?
So there are two charts on the top one. So is the direction of the nystagmus changing?
No, sir. Here. Sir, I am considering.
The red and the blue
So
one?
the red,
So red one is for the right eye and the left one is for the left eye.
The red line is the horizontal movement of eye, and the black one and
It's for
the
vertical.
dark violet, niche wala,
Nature of
it is the vertical eye movement. So that is
no.
You would first tell the top rectangle belongs to the right eye,
top rectangle is right eye.
bottom rectangle belongs to the left
Left
eye.
Left eye.
Because this patient is having a torsion nystagmus
So
also.
that
That
is
is
fine.
why.
The top part, the darker shade.
Black line.
This one.
So I just so the convention is this. Morning Prateek showed, as if the patient is facing you. This will be the right eye, this will be the left eye. This region belongs to the right eye. This region belongs to the left eye. So far done. In each region, the red, this region, the red one, the legend will be somewhere here. It is written here. Red is right horizontal position. This is right vertical position. Similarly here, the blue is the right horizontal position. The violet is the left horizontal position and left vertical position. So, if you see the horizontal nystagmus here, it is slowly going to the right and going fast to the left. Slowly going to the right and fast to the left. So this is both is a left beating nystagmus. You see the vertical component, both are showing upbeating. So you see horizontal and vertical. So basically this is oblique. Torsional is not represented on the video.
VNG.
Torsional means looking at the video. So if you see any VNG standard VNG so far, there are only two lines. There is no third line. Eventually one day the torsional will become available, but as of now it is not.
Thank you, sir. Then Alexander's law, we already talked, it should follow Alexander's law. So there should be a horizontal nystagmus in dark, and then on center gaze, left beating nystagmus is seen, right gaze minimal or no nystagmus is seen, and left gaze, left beating nystagmus increases. So in the center, here we can see left beating nystagmus. It is present because in the cases of vestibular neuritis or AUVP, the nystagmus is present throughout. Then in the right gaze, minimal nystagmus has been seen. But as we move to the left gaze, the intensity has increased drastically in both the eyes. So it fulfills the criteria of Alexander's law. Then saccadic saccades, we'll see nystagmic intrusions. Normally this is green is the target line, that is a tracing line, and right is for the right eye and blue is for the left eye. So while moving the eyes from one object to one point of movement to another on fast, in a real case this should trace exactly like the green. But here you can see right beats. This I am discussing about another case because for the same patient I didn't have this graph. So this is right beating. Why? Because in the baseline nystagmus was all the time present in performing all these tests. So it comes with this reading. We call it as nystagmic intrusions. That is right side. Here it comes. When it moves towards the left, it's normal. In the center, it was normal. And when it beats towards the right, when the eyes is towards the right, there is nystagmus. I'll play the full video because it happens every time, so you can appreciate it. So, impaired rightward pursuit intrusions. Similar way, when slowly we are moving with a constant velocity when we are seeing, so in a predictable fashion, this is green is the tracing line, and when in a normal individual, exactly that same waveform will be done. But here, the baseline firing is of a rightward nystagmus. So, at the peak, when the rightward movement is at the maximum, here are the nystagmic patterns. So, we call it as pursuit intrusions, both in right as well as left hand. See, some kind of a jerky movements are happening at extreme right when we are performing the test for smooth pursuit. Then high frequency head shake. There is no paper written about it, but it was discussed in Varani last year. So after a high frequency head test, when we move the head 20 times fast movements, so afterwards there is a horizontal nystagmus present. So here right now eyes has been high frequency head shake has been done. After end of the movement, there starts the nystagmus pattern. And it is continuing throughout. This is the pattern. After performing the test, it's been right beating nystagmus present throughout. At the 24 seconds also, 48 seconds till where we have seen. So this will be present in the acute phase of AUVP. And the classification is A1. Then second is 1B. See, after performing, and slowly the nystagmus is gone. Again we are performing because in the center it has, patient has closed his eyes. See, this is the graph. Initially, after performing the test, the nystagmus was present, and then later it weaned off. It stopped. So it is seen in the fully compensated phase of AUVP. Other examination, as discussed, Hints plus examination. Hints plus stands for head impulse, nystagmus, test of skew deviation, and plus for audiological evaluation. Cranial nerve examination, test to check gait stability. Cervical and ocular vamps. Then treatment. In acute phases, we can give dimenhydrinate, ondansetron, methylprednisolone, depending upon the body weight of the patient, and it usually recommended to start within the 3 days of onset of the disease, and it can be then it is modulated in the tapered dose over the weeks. Then other drugs are promethazine, metoclopramide, domperidone, and meclizine. Dimenhydrinate and meclizine remains the drug of choice in patients while experiencing this disease in pregnancy. Now, vestibular rehabilitation remains the mainstay of treatment. It is scheduled in 3 phases over the duration of 15 days. So, acute phase, when patient is lying on the bed, it has 4 exercises explained over a period to be performed over the period of 3 days. Then recovery phase 1 starts when patient is able to sit up on the bed, and it constitutes of 6 exercises over the duration of 6 days. And recovery phase 2nd, which is when patient is able to get up. It has 7 exercises which has been done over a period of 6 days. This is a huge topic. It can't be explained in just a short time. And then few extra exercises which can be performed using a VNG machine, which we can give any point of the duration is not that better. The early the rehabilitation started and given properly, it gives the best outcome. So we do Saccard and Perceive test in both horizontal and vertical plane for 30 seconds. If patient is able to tolerate this, then we proceed towards orthokinetic and subjective visual vertical on respective EEG systems. So when patient is able to tolerate all this, eventually he will feel better and the lifestyle would be better. Thank you.
So we have two more, Dr. Amit cases, sir, to start. Interesting cases in vertigo.
Asked me that what will be your topic. I told him that I will present some cases, and what I will do is that I will put I have 6 cases and there are around 5-6 tables where the people are sitting. So every case will go for solution at a table. So where there is a maximum attendance. Okay. So we will start with my table on the right side with the first case. So these are all history-based cases, and then what we will do on each one of it is important. Hello, I'm audible. So this is a 45-year-old patient. This is for the table left side. Old patient present with rotatory vertigo lasting for 2 to 4 hours, associated with nausea and vomiting since last 1 year, with vertigo episode increasing since last 3 months. It has increased. Also complain of tinnitus. The tinnitus character changes before the episode of vertigo. When elaborating the history, he denies having hearing loss but complains of heaviness in ear during episodes of vertigo. He also has history of migraine in past, but he is symptom free since last 10 years. So what comes to your mind? So looks like some Indian disease, but the only caveat here is down is that there is a history of migraine. Okay. So the question next is the diagnosis you have already. What test you would like to do?
Audiometry, ecology and glycerol test.
So audiometry and SRSI is a test where they increase 1 decibel every time, and then they count how many times the patient is able to count. So they give around 10 to 20 increment of sound, 20 increment at 1 decibel. And so exactly we did this for, so you can see here that on the left ear side, this left ear side, we have 90% sensitivity, and on the right side 25%. And as Rajat said, maybe that in the institutions we get cases when the patient is already suffered 3-4 years from the Meniere's disease and they are referred later because of the recurrent. So we do not see the low frequency loss, we exactly see the flap curves. And then, so this patient, you can see that this is a nearly 50 decibel of hearing loss, right? We also do a speech audiometry. So this falls in a category where the serviceable hearing loss is not there on the left side. So apart from for the acute attack, we are giving Vetelstein and pantoprazole, domperidone and lasilectone. I am a big fan of lasilectone, which contains of both potassium aspirin and thiazide diuretics. But I use half the dose and just take out the sodium, and then we can monitor the sodium from the urinary spot sodium. And then the first dose of intratympanic gentamicin is given, right? And then there is a dietary is low salt and lower. So you can see that the patient has come from 8 months to the 9 months, a year, a month around, and then after that everything is stopped and his vertigo episode has come down. So for the acute attack, we use sometimes the Vetelstein for a month, but for the longer duration, our treatment protocol is for long-term lasilectone and then intratympanic gentamicin, and if required, then we go ahead with. Then this patient comes after 6 months with the vertigo, and the resident said that he is having an attack of vertigo. Detailed history told the vertigo is more severe and lasting few minutes, increasing on lying down and turning on bed. DD now. Now that the patient was asymptomatic for nearly 6 months, but he came back again. What is the? Yes, exactly. So it can be both. You have to do a Dix-Hallpike test. So it is not necessary that what was disabling. It is very easy. Earlier I was also that okay, now again 6 months mein aa gaya, what should I do? But then a percent of Meniere's may have a migraine and all that thing. And this is what this I made when I was sitting there. that there are the cases where there is a clear-cut boundary, that is the migraine. There are the cases where there is a clear-cut boundary, there are menias, and there are menial migraines MM complex, menial migraine complex, right? And please do not try to find out that how many of menial migraine complex are menias. Do not waste time there, and do not waste time that how many of them are migraine. There are so many criteria, so many things happening. But if your patient is of one variety, and the next time when you come for the assessment of vertigo, his vertigo character has changed, and the other things are there, the history of migraine, then do add a migraine prophylaxis. Whatever you feel deemed sign for us, Pranazine works in a longer terms. And also sometimes we add magnesium. There the presentation when the patient of menial disease have 10 to 15 years down the lane, then you can see that the left side is more severe loss. This is a case of bilateral severe menias and follow-up since last 15 years with us. So these are all our menias disease cases. So the one spectrum which it covers is the menias and menias migraine complex. Okay, so the next case goes to the center table. The Pratishta is there. And 20-year-old patient complained of vertigo since last 20 days with hearing loss and headache. He has no history of ear discharge in past. And his anteroperculate test showed deviation to the left side. So actually the patient has 20-year-old, vertigo since last 20 days and hearing loss and headache. He also has headache at this point of time. He has history of ear discharge, but at present there is no discharge, right? That is what the, so what do you think a 20-year-old, what you should do? What test?
Otoscopy.
Yeah. So that's correct, but that's not for your answer, right? It was for the table. So the 20-year-old with 20 days problems of this. So it is important that you do otoscopy. So it was a case of headache cholesteatoma, right? And test you do is first most important test is that you do is the audiogram to see that what it is there. And this was the CT scan. So you can see that this patient has cholesteatoma with a clear-cut lateral semicircular fistula. This patient is still in the ward, but we did an MRI because there was a loss in this posterior fossa dura. So when you have something like this, you always do an MRI. And MRI, you can see that there is a lesion there, and on diffusion there is a restriction. So, but there is no intracranial complication. But in these kind of patients, you may have cerebellar abscess. So be wary of that. So this patient we give antibiotic for 5 to 7 days, and then eventually we operate it. But all patients with LSS fistula do not have a complete hearing loss. But this patient, the last patient did not has a profound hearing loss, and the fistula test was negative in that. For this patient, again a case of right side LSC fistula. With this, the fistula test was positive. So when there is a profound hearing loss, the labyrinth is dead, the fistula test will be negative. So okay, so then case number 3, we can try the front table. A 53-year-old female patient presented with dizziness, vertigo, imbalance since last 1 year. There is no history of hearing loss, no history of migraine or any other complaints. She has history of right side headache and some numbness near ears. So the patient has complaint of dizziness, vertigo and imbalance. Okay, 3 things. And no history of hearing loss, migraine and other complaints. This is the audiogram. Now how you will move ahead. Question? What is the probable diagnosis? Since 1 year. Yeah.
Vestibular migraine.
Okay. Triple PD, right? Is there any role of MRI? Would you like to do an MRI? Because there are 3 things which is dizziness is there. There is vertigo and imbalance. Okay. So the diagnosis came out to be rare, but in these kind of cases, after an audiogram, you would like to do an MRI because anteroperculate test was negative, right? There was no swelling, rhombus was negative, everything was normal. So this patient came out to be a case of schwannoma, which was compressing on the middle cerebral peduncle, you can say, This is a schwannoma, but not a vestibular schwannoma. This is a hypoglossal nerve schwannoma, right? So you can see that this here, the middle cerebral peduncle, which give the masses to the coordination between cerebellum and vestibular nuclei, was getting compressed. So the patient did not have any hearing loss, no hearing loss at all, and the patient, because of this mass effect, there was some headache. So this is a sinister thing, but sometimes can present. So as when you suspect that there is something is not, there is no history of migraine, there is no history of any air discharge, and there is no hearing loss, still the patient complains, then do not ignore the patient of complaint, give him a Vertigo and go away. Sometimes you have to do an MRI. So this is one of the rarest things, but yes, with the similar complaint, we have seen a small acoustics, at least 10 to 15 in my career, that there is a very small acoustic. The patient with acute vestibular syndrome have sometimes acoustic neuroma. So you have to do not, even if you are not very sure, then if you have to write medically that okay, MRI may be needed if the patient symptoms do not resolve. So that is always a good thing to do in today's world of. Then we operated upon this patient and this patient improved. Then left side table can take this. 35-year-old male with sudden onset severe vertigo, vomiting and facial palsy for the last 25 days. The vertigo has improved and there is no history of ear discharge, migraine, hypertension or any other comorbidities. So here there is a facial palsy also. So what do you think that it can be?
Facial
Yes. So stroke, facial nerve schwannoma. So this patient directly warrant a MRI scan, right? So in the MRI scan, what we see, what we saw is that you can see that there is a fluid here and there is no fluid here. So then they first said that it is a kind of acute vestibular syndrome on the right, on this side, and the patient may have the Bell's palsy together. So this will be a case where the Bell's palsy along with the acute vestibular syndrome. But then when we the patient did not improve after 2 to 3 weeks of the facial palsy did not improve, it further deteriorated. Then we discussed the case further. Then they said that there is sometimes the ganglioneuroma present like this. Okay, so the ganglioneuroma can present like this, that where there will be no CSF in the internal acoustic meter. So it was probably that neuroma was growing, but it was not an acoustic neuroma that to give a typical symptom. But there was this subtle thing. And then we planned a labyrinthectomy along with the excision of schwannoma, and you can see that this is the facial nerve decompression we did. So this is the facial nerve from entire segment from CP angle to the labyrinthine and this. So if there is anything which is not going into any syndrome, which Srinivas sir has said, it is a bilateral vestibulopathy, it is a unilateral vestibulopathy, or it is some migraine. If you are not into these three things or menias, then if there is something, anything which is different, and the vertigo is not so severe, then definitely get an MRI done. Coming to the case number 5. Yeah. Yeah. Yes, that was what, but there was no otical system, no vesicles, nothing. So it was diagnosed initially as a case of that there was a severe inflammation in that area. That by both 7th, 8th nerve complex, patient has profound hearing loss, that was diagnosed. But when the patient did not improve in any count, the hearing, the vertigo became better definitely, but the hearing and the facial palsy deteriorated over 3 weeks. Then we they said, radiologist, can you review this? Then one of them said that the ganglioneuroma can present. And finally the histopath report came as the ganglioneuroma from the superior vestibular nerve. So sometimes these cases can come. I am just highlighting that apart from the syndromes, what else can happen. Coming to the case number 5, a 35-year-old present with history of vertigo, dizziness, imbalance. Vertigo was lasting for few seconds to minutes and more on turning in bed. He has no vertigo in sitting position, but ghost imbalance in standing position. Dick sulfide positive in right AC and Apple maneuver was done. Patient was related, but he continued to have imbalance. So this was a case where there is a vertigo, dizziness, imbalance, and we diagnosed it as a case of right posterior septal place was done. His vertigo become better, but the imbalance did not improve.
Bilateral vestibulopathy.
Yes, one possibility. Other, I think, sir touched upon this Srinivas sir.
Short arm.
Okay, but the vertigo, there is no vertigo now.
Residual.
Right, okay. So we are thinking about this. We are not thinking about the patient as a whole. Right? This is a vegetarian patient. Right? So you have to do vitamin B12, vitamin D. Vitamin D came out to be less than 10 and B12 level was very, very less. And 6 doses of B12 injection and some doses of vitamin B12. The patient was absolutely fine 3 months later. So, I mean, you cannot ignore that for the transmission of signals, the vitamins are required. And in a vegetarian patient, and I've seen sometimes many of these patients has anemia also because of the B12 is not being observed from the stomach. And now we have a spray which is called Major B12. If the patient is phobic to injections, you can just use the sprays. I think the neurologists use more than us. Then coming to the probably the last case, a 55-year-old female came with history of sudden onset severe vertigo, vomiting and imbalance 3 months back. Treated with anti-vertigo medication and vertigo became, but persistent dizziness and disabling imbalance was there, such that the patient is not able to do the routine activity. So the patient was referred to me from Gwalior that the vertigo is now better, but she is such that she does not want to move from one place to other. She barely goes to the bathroom holding this, and Unterberger so minimal swaying to the right side, thrombus chest, the patient was not able to maintain balance, but if supported by one finger, she was able to maintain balance. Triple PD, right? So you don't need to do anything. The patient already come with an MRI. When they come to us, they already had an MRI. MRI is normal. B12, they have already taken 6 injections of B12. The B12 was upper limit of the this. Vitamin D was supplemented. Still the patient has this. And PPPD counseling, benzodiazepine, SNRIs. Sometimes use clonazepam. VRT is very, very important. In any vertigo case, VRT is very, very important. So you can see that this is a small video so the patient is saying that I am not able to walk. I will fall. Right? The husband is standing at the back, but so as soon as I put a finger, she is stable. Right? Then again, she is not falling. The husband was like, okay, she will fall because she has never been this. So this you can see the husband hand coming that okay, she will definitely fall. But you have to instill confidence into the patient. You have to instill confidence into the caregiver. Okay, she is fine. She had some problem, but now she is fine. And even then, if I will fast forward the video, she was able to do Unterberger, right? Not she was afraid, so she did not put his feet up, right? So this is just 2 minutes. I do it for everyone, and then after the counseling and some VRT and all that, this patient become better. So with this, I end my presentation. There is one more case if time allows.
Yes, sir.
Okay, I am just covering the entire spectrum which we get. So the last case is 45-year-old male complains of vertigo lasting few seconds with episode like this more than 100 every day. Right? Few seconds, more than 100 every day. He is diagnosed with vestibular migraine and have partial relief of symptoms since last 1 year. He is already on anti-migrainous medications from a neurologist. Now he has tinnitus and mild hearing loss and referred by a neurologist for evaluation of hearing loss. Now he complained that he has some hearing loss and all that. So what is your TD?
Vestibular paroxysmia.
Right, vestibular paroxysmia. Straightway it goes for a case of vestibular paroxysmia, and we know in vestibular paroxysmia earlier there may be a insult on the vestibular nerve, but in slowly it can compromise the hearing. And so this patient has, and in the Chawda grading, many a time I get this kind of reports from all across UP or India that there is a vascular leak, can you decompress it? But if it is not grade 3, we do not touch it. And even in grade 3, we do not touch it unless it is hampering the hearing and it is going into a place where the patient is losing the hearing fast. So we follow it and then we just give the carbamazepine or sometimes the oxcarbamazepine is my favorite because it causes less sedation, lesser side effect profile than the carbamazepine. But it is a grade 3 because many a time I get grade 1, grade 2 and grade 1 on right side, the symptom is there on the left side. So this is not, unless it is a grade 3 and which you can see yourself that okay, on the place of this, I think this is a T2 weighted, heavily T2 weighted scan should be able to see the nerves. You can able to make this is a semicircular canal. LAC is seen most commonly in the cochlea. If you are able to see this scan, if there is an endolymphatic sac, you will be able to see in this space that there is an endolymphatic sac. So if you read only this part of the scan, forget about everything. Everything else the radiologist will report, right? If there is anything else, the radiologist will report, but he may miss these small subtle things at the CP angle, and always write a patient to have a contrast imaging and heavily T2-weighted cyst sequences, you call it, or whatever you call it, depending upon this. So you have to see that this CP angle, and if you are happy to see the CP angle, many times we see report, we do not see an MRI, but it is a, if you are in a neurology or vertigo practice, you should see the CP angle yourself, that what is happening there, is the fluid is there or not, what's happening to the labyrinth, is there is any discontinuous, so this is important for this. So with this I will end my presentation. I just wanted to present the various parts which can mix and match and can confuse you, but if the history is taken well, most of the time you will be correct. And when in doubt, like Dr. Srinivas said, an MRI done. It's imperative to get an MRI done if there is a atypical symptoms like a headache without a migraine, gross imbalance, and do not forget that the patient may have nutritional deficiency, and if it is recovering from vertigo, PPPD may be there.
Amit, if you are the first person to ask for an MRI in such cases, you ask for a contrast enhanced MRI?
Yes, always, sir. Always. I cannot keep it for the second setting because it's difficult. The patients are charged accordingly. We usually, but if a straightaway patient comes off linear disease, I do not ask for MRI. If my SSI is positive, if it is.
The reason why I asked you, as you also have a tertiary based practice, I also get to see so many patients who have been already seen by others. So they already are carrying a MR scan with them.
So that's what I said, sir, that in that MRI scan, if you are able to get cyst sequences, you see if there is grossly normal, I don't get any contrast. You can see, it is not that only in contrast you will be able to see, you will be able to see the discontinuity in the CSF which is going into the two nerves from the cochlear side and from the vestibular side. So then I don't, but sometimes the MRI would be there, but there will be no cyst sequences. So you just ask the person to go to the radiology center. He charges 200 or 400 rupees and give a cyst sequence of the same patient because they usually take the cyst sequences. So if you do not mention that the 7th retinal complex to be same, even then also they get a cyst sequences. It's a heavily weighted T2 sequence, and they can zoom up and then tell you the reports. So when a patient comes from outside already with MRI, I do not repeat MRI. That was your question. And if there is no cyst sequence, I will like to have a cyst sequence. I will tell patient that to go to the radiology center. At the max, they can ask 200 and 400 rupees to a single plate, or they can do in this. If they have not done the study, they usually do it. They usually do not say no to this.
That data is already there.
Yes.
So
Yes.
so
So they just give a printout, or they sometimes they send us the entire thing on the WhatsApp or by QR code. Now they are giving a QR code so that you can see yourself. Okay.
Thank you so much, sir.
Thank you so much, sir. Now the last talk of the evening. May I invite Dr. Pratishta Sachan ma'am to present her talk on lateral and posterior canal BPPV.
So, very good evening to all. First of all, thanks to organizing committee, Dr. Prateek sir, for inviting me. Thank you so much, sir. And today my topic of presentation, how to match the nystagmus to the correct maneuver in the BPPV, a puzzle. So let me start with the puzzle round. This is the dick salpic position in the right and supine head extension position, what we will get the nystagmus. This is the canal, anatomy of the labyrinth arch. This is the posterior canal, and we will see the nystagmus. We can correlate what is it actually. This is upbeat nystagmus. What is it?
Right.
Quick.
Right
Posterior
posterior.
canal. Now this is. Tell me fast. Quick.
Right
Upbeat nystagmus with the dorsal component. Now it is downbeat component also. So what is it actually? Just now the direction is changing. It's become vertical to the right horizontal side. Now it's completely horizontal nystagmus. You can see here. What is it? So just review of this initial. There is a, we have to match the nystagmus in which canal the particle is moving. Positional test, we are performing the positional. So you can see here, this is the posterior canal. Initially we will get the upbeating nystagmus. So particle is moving in the canal from here to here. Apart from, there is again downbeat nystagmus. Then what is it? Is it central case? Why there is a direction change in direction in the positional one? Is it central one? No, it's not central one. Is it the particle is rolling back in the canal, so that we will get the reversal of the nystagmus in the case of BPPV. Particle fall under the gravitational pull, it's gaining velocity. Again there is a decrease in slow phase velocity and particle is leaving back rolling of the particles. That we are getting the horizontal, upbeat nystagmus, and after that there is a downbeat nystagmus. Apart from, there is a torsional component. I will come back after this. There is a horizontal nystagmus at the end. What is it? Vertical nystagmus induces the vertical beat of the vertical canal stimulation, so that we will get the vertical nystagmus. After there is a horizontal nystagmus. This is the horizontal canal stimulation. So while it is an upbeat and there is a horizontal beating nystagmus, is it what is it actually?
The conversion of posterior canal to posterior.
Yes, this is a good question. Now we can start from beginning. We cannot forward here, so that we have to go through full. This is not the conversion, not LV. Initially there is a right beat also seen here. If there is canal conversion, you will get the vertical nystagmus prior to the horizontal nystagmus. This is not the canal conversion. Particle is moving from here to here. If there is canal conversion, you don't get the initial horizontal nystagmus. You will get in the upbeat nystagmus, but before that there is a few horizontal beat also seen here. So we can say mixed multi-canal, but not the canal conversion. We can mark the footprint of the nystagmus, we can reach the diagnosis. This is not the canal conversion, because for canal conversion, particles will move from here to here. Initially, we will get the upbeat nystagmus, then we will get the horizontal nystagmus. But here, what is happening here? There is initial horizontal beat also present. So we can say there is some particle is in the horizontal canal, that we are getting initial horizontal nystagmus also. So, what is here? So this is the horizontal canal part. I just want to show you the particle is moving in the horizontal canal. Particle is moving back here in supine head extension position, right side, so that we will get the geotropic right beat nystagmus in case of big salpic supine extension position. We will get both upbeating nystagmus and horizontal beating nystagmus in the both single big salpic supine head extension position. Second thing, the canal projection? How we can match the nystagmus? Is it from the superior canal? Is it from the horizontal canal? Everyone, as Pradeep Vundavalli sir explain everything. Today they explain what is it here. Like in posterior canal, superior oblique muscle is stimulated. Contralateral inferior rectus is stimulated. Why we will get the dorsal nystagmus? Everyone is aware of it because superior canal is having the action. Primary superior oblique muscle having the action of the intorsion, and secondary the depression, and third is abduction. So what is happening here? If we are like this is the our right eye, and right posterior canal is stimulated. Superior oblique is attached on the upper surface. We are just superior oblique is stimulated. So there is a torsional pulling action is more here. So that we will get the torsional component more here. But if there we are pulling from here, there is a depression. There is a not torsional component doesn't seem very well. Cannot visualize very well. So if we are seeing from the different gauges, we can judge where is a torsional. We can assume that particle is on the posterior canal and having the torsional component more, while we are seeing on the temporal side, gaze side. So torsional part is more prominent. We can judge the site of the nystagmus. क्योंकि हम जब practice करते हैं, we have seen that कि कौन सी canal involved है. We have to do right or left. This is more confusing. अब beat तो हम देख लेते हैं, but we cannot determine the site of the which site is involved. So we can see with the pulley action of the superior oblique, we will determine the torsional component is more prominent in which side. So while we are seeing on the temporal side, like superior oblique attached on the upper wall, so having the torsional component in torsion seen here. Well, we have to determine the side, which canal is involved, right side or left side. We can say the patient just see on the right side. During the distal supine head extension position, the torsional component become more prominent because of the superior oblique muscle having the torsional more things that is more prominent. So we can determine the site also here. Another picture. We perform the McLure-Pagny test here. You can see the horizontal right beat nystagmus. So which canal is stimulated here? We are performing the right lateral position. This is the right lateral position, and we are getting the right horizontal nystagmus. Which canal is stimulated here? Horizontal canal, because horizontal canal only beat stimulate only the medial rectus and adduction. There is no torsional part. Only the primary action is the horizontal adduction. So we will get, during the horizontal canal stimulation, we will get only the horizontal nystagmus. There is no torsional component in case of horizontal canal stimulation. Sir, we can make forward it. Right. What happened? Why we will get the horizontal canal stimulation here? There is a right horizontal canal particle in supine position. The most dependent position of the canal is the inferior part of the canal. In supine position, the most dependent, all the particle autolytic mass get deposited in the dependent position, inferior position. And while we are moving to right lateral position, then what happened? The basic base of the particle from here to here, move from here. So that's why particle is moving from here to here, and eyes are moving. Nystagmus is beating downward. So that we are getting the horizontal nystagmus, geotropic nystagmus. Apart from, we have to study like canal orientation. There is an angulation present in the canal. We will not exactly horizontal and vertical. There is an angulation present. That's why we are getting the some in between horizontal and vertical component of the nystagmus also. We can see again the supine position. We will get the particles move again. There is also nystagmus in the most dependent part. Again there is in left lateral position. Particle from the most dependent position move here. So that we will get again left beat nystagmus because particle is moving from this position, most dependent position toward the utricle. So we are getting these type of the nystagmus. Now this is at the end we are getting the left beat nystagmus here because the particle is moving in the canal. So in horizontal canal we can see here the ipsilateral medial rectus, contralateral lateral rectus. So there is a horizontal nystagmus seen in case of horizontal canal stimulation. Now the question arises, why we will get only the upbeating vertical nystagmus in case of anterior canal? Why we are not getting the dorsal component more? What I just found, this is my insight, in anterior canal there is superior rectus muscle, that is primary action is vertical, contraction, up contraction. So that's why beating downward. There is no torsional, there is a secondary action. Secondary action is the torsional component. So that's why we are getting in anterior canal we will get the vertical nystagmus, downbeat nystagmus, not the torsional one. So we have not able to get the too much torsional component in case of anterior canal stimulation. Again, there is a positional test, pitch forward and pitch backward. What we are getting during the pitch forward test, what we get, the particle is moving in the from canal. So in pitch forward, particle is hinged here in the posterior canal, but in case of lateral canal, particle is moving from here to here. So that's where we are getting the same side of the nystagmus. So you will get the horizontal nystagmus in pitch forward. That can determine the site also, which site is involved. If the right beat nystagmus is present, then the right side of the canal is involved. This is just a movement of the particle will determine the which side is involved, which canal is involved. Nothing, no procedure like no maneuver will decide which canal is involved. Apart from there is a pitch backward test. Which canal is stimulated more? We can see here. Now the upbeat nystagmus. Then which canal is stimulated? Vertical nystagmus seen. The posterior canal is involved. It can be anterior one, but here is the most common one is the posterior canal. So part in the pitch backward position like this one. So which canal is stimulated? Particle is moving from here to here. So we will get the upbeat nystagmus due to the posterior canal stimulation. So these are the pattern we will get stimulated during our we can link with the nystagmus pattern due to the extraocular muscle contraction stimulation. We will get the nystagmus pattern. We should be aware that this is not the central one, this is a peripheral one. We can decode the nystagmus with the nystagmus pathway. So in the pitch forward, we will get the right beat nystagmus, right iliac canal stimulation. Pitch backward, we will get the upbeat torsional component, right torsional. So we can determine it's the right posterior canal, BPPV. This is the Berani Society Uppsala collection of the human inner ear cast. I have just taken from this. You can see here there is a different angulation we can see here. Same in the cast, you can see there is a canal, lateral canal, posterior canal, anterior canal. There is a crust coming here. This is a cochlea. So we can determine the nystagmus while the particle moving in the canal in the twisted part of the canals. Apart from there is a various different type of the BPPV we have found regularly day by day. We are just improving this which canal is involved. Which canal is involved and where the particle is. We can justify the position of the particle. We can challenge the particles here even by reading the footprint of the nystagmus. How we can? This is the cupulolithiasis of the short arm. This is cupulolithiasis of the short arm. Canalolithiasis of the short arm. Cupulolithiasis of the ampullary part. Particle is here and here. This is the stable position so that we will get the particle accumulated here. The non-ampullary part of the BPPV, posterior canal. We can judge the apogeotropic of the lateral canal. We can judge the arms of the lateral canal is also involved. We can judge the twist and turn, that is the most common site of the canal jam in the lateral canal. So we can assess the position of the particle even with moving with the nystagmus pattern. We can match the footprint of the nystagmus. We can assess the position of the nystagmus also, position of particle also. So this is the and we can assess why this is the different pattern we are getting. why this is like apogeotropic lateral canal is more common. You can see here, there is a deep where the particle can stay here. When we can stay somewhere, we can just we can stick somewhere. So where there is a most dependent part, the bulk of the particle deposited here, that we will get the canal jam here. So it's all the type of the BPPV, but what we are just studying regularly, cupulo, canalo. This is depend upon the canal angulation, and that's why we are getting these type of the BPPV pattern. Canal jam here because there is a twist present. There is a most dependent part, the particle gets stay here. We get the cupulolithiasis here because there is a deepening of the hair. If this is the exact one, we will particle get stick here if the long-term BPPV is not recovered. So that we will get the apogeotropic pattern in these patterns because some particle get stick at the level of cupula. Apart from why we are not getting anterior canal too much, because we can say there is such a acute turn. No one can stay on such a slant part of that. We will get the cupulolithiasis here, but we cannot get the slant part. We cannot. Nobody can stay. Even the particle cannot stay such a slant part. So it get fixed at the regular position. So that's why what I'm thinking anterior canal is a rare one. It's depends upon the anatomy of the canal. So this is a different what I draw this is a canal jam. How we will get the nystagmus pattern here. This is the angulation present in the lateral canal from the horizontal part, so that we will get the canal jam, and how we will get the spontaneous nystagmus even too. So we will get the spontaneous nystagmus even in case of BPPV. So don't get confused, for the spontaneous nystagmus is found in case of BPPV. We will found spontaneous nystagmus in case of BPPV too. This is my research work. We can mark the beat to beat nystagmus pattern, and this is my research work also. Where is the canal jam? Where the particle move? Where is the particle written back? We can record the nystagmus slow phase velocity by which we can reach the where is the canal jam present? Where is the particle get accumulated here? We can decode the anatomy of the canal also. So take home message, by observing the eye movement, we can decode the journey of the particle in the canal, their location, mass, size, gravity driving drift, direction of the fall, reveal them through these subtle ocular signals. So we have to catch the ocular signals so that we can reach the different type of the diagnosis. Every disease having their signature pattern. We are not aware. In future we will definitely catch the signature pattern of the different diseases. So with these same elegant eye movements as our guide, we can steer the particle back to where they belong, restoring the balance with the precision. So match the nystagmus to the correct maneuver. Maneuver is everything is clear in the previous session. And first of all, I just want to thanks to Dr. Srinivas sir for their positivity, for the teaching us, so that we can move in this pathway and we can doing the revolution all over the world. Thank you so much, sir, for your digitalize the neurology so that we can able to reach at that height and present it at the world level. Thank you so much, sir. Thank you. For any queries, yes, sir, please.
Posterior canal cupulolithiasis and bilateral posterior canal BPPV. These two conditions.
So tell me the first one.
Cupulolithiasis, right posterior canal.
I just want to show the picture, sir. Please connect, sir. Just connect the picture so that I will explain. So first condition is
Posterior canal cupulolithiasis.
yes, sir. So in case of cupulolithiasis, the particle is here. So that we will get downward.
Marker is not there. It's not there. Marker is
Sir, actually marker is downward is acute.
Yes.
So cupulolithiasis condition is the particle is posed downward, so I will beat upside. But in inversion test we will get the better read. The cupulolithiasis better will differentiate it with the inversion test. Yes. This one, the cupulolithiasis, giving the force downward. It's just a vector sum. Eye movement is just a vector sum. The party is moving, like giving the pressure downward, and eye will move upside. We have to confirm this is upbeat nystagmus. We will get this is persistent. That we can think this is cuprolithiasis because there is a particle stick here. We cannot replace the particle. In the canalolithiasis, particle is moved back from here to here. When it gets stabilized, nystagmus will disappear because there is no canal stimulation. But here what happens? You will continuous, you will get the stimulation so that we will get the upbeat nystagmus persistently. We have to confirm with the inversion test also. By the inversion, there is a reversal of the nystagmus seen. So this is the cuprolithiasis we will get.
Position 5.
Position 5, this is the cuprolithiasis on the short neck arm side. This, that will also get the same, but nystagmus doesn't resolve with the manual because we have to perform the bow and like the bow pitch test we have to resolve because we have to strip these particles to the exact cuticle part. So we have to perform the different maneuver. We have to do again and again just to remove these particles from here to here. This is the short neck arm also, in which we will get the sitting of vertigo also. We will, while sitting, we are just giving the, for the fraction of second, we will get the nystagmus during the sitting or supine to sit position. So that we have to strip these particles in the utricle because this channel is very clear. Particle might be stay here, might be shifted here. So we will get commonly these picture. Now in scenario, the positive cuprolithiasis is very commonly we have seen in the practice. Yes, sir.
Can I simplify it and correct me if I'm wrong? Sir, when you have cuprolithiasis, the otoconia sitting on the cupula, you want to push on the cupula and in the posterior canal. When you push it, the endoluminal movement is such that it is amphilofugal. That means it is away from the utriculofugal, which is excitatory for the posterior canal. When it is excitatory, the posterior canal is going to push the eye movement down and you'll have an upbeat nystagmus. That is my understanding of it.
Perfect, sir.
What about bilateral posterior canal cases?
So we will get the right torsional supinate extension, we will get the right torsional upbeat and we will get the left side with the torsional with upbeat components.
Sir, Pratishta, there is a caveat. All this is coming from Dr. Srinivas.
Yes, definitely.
Attending his case.
He is your senior, sir.
No, I'm not senior, I'm
Your senior, of course. Oh, previous batch. So, she has the eligibility to rag you.
That's why I said, correct me if I'm wrong.
So now I request everyone to come forward so that you understand the you can leave your baggage there or yeah, we can stand here so that we can see how the eye moves and we can understand all the members.
हैंड जो है वॉल पे कर हो सकता है मैं कैमरे से लेती हूँ
He was kindly brought it so that he can share with all of us. So the idea now is going to be understand the graphs that come from the ESG system. Okay. If some of you want to collaborate with audiologists for starting any center or anything like that, or in your place, I have a very good friend in Ranchi. His name is Vivek. I don't know, some of you know him. He's an audiologist. He's starting some centers, and he's also looking for partners to collaborate with, so that he can put up the equipment and then do the testing for you. So if any of you want to get in touch with him, his phone number, his name is Vivek. Just get in with Vivek Mohan. Me, Prateek, anybody, just get in touch with you and get in touch. He's already started one setup in Ranchi, but then he's also looking for other people to collaborate. Because this is also there. Some people are like, "Mere ko khud ko time nahi hai. If somebody else does it, now coming to this thing, you're seeing the eye video. You're seeing the head. That head is doing exactly what I am doing. Correct? Can you see? The top of the head is my future.
Now, not only our.
The see the eye. Now the convention is very simple. Okay. The convention is that is the right eye, that is the left eye. Okay. Exactly as if the person is in front of you. Okay. How you examine clinically when the person is in front of you? That is how the video is shown. Like, as if the person is in front of you. Close the right eye. Vin Diesel closes his right eye. Okay. Close the left eye. He's closed his left eye. Close both eyes. He close it. Okay. So like this. The difference between blink and wink is blink. Yeah. Fine. So now this part of the graph belongs to the right eye. This part of the graph belongs to the left eye. Okay. This you have to, like, if you are using a different system, you should know what is the convention in that particular system. Right now, I can tell that my convention should become the standard convention for everybody because I have probably the highest number of installations between my previous device and this device. Previous device in the previous company that I made has more than 900 installations. And the present device, with all the blessings of all the friends from across the country, we are reaching 150 installations. So around 1050 installations, even across the globe, for any one company is the biggest. Okay, one particular manufacturer or innovator. Which means what we are following should become the global standard. Okay. And we have that. So this comes the right, this comes the left. Here we have introduced something called, this is the head, for the head. So right eye, left eye and head. Okay. So now, you can see here there is something called a line, red line, it is marked right eye horizontal, black line is written right eye vertical. Okay. So let us first concentrate only on the right eye for some time, though the left graph also will be coming. Okay, it will be coming. Now, just see the red line position. How is it? Is it coming as a flat line? In ECG, flat line means? Here it is no movement. Okay, that's all. Now, what happens to the flat line? I will move the eye to the right side, just see what happens to the red flat line. Okay? What happened to the red flat line? Went up. Now it came back to the previous position, correct? Now it went down. Is that right? Now it went down. Correct. So now, so what does it mean is, when the eye goes to the right, the horizontal line moves upwards, correct? When the eye goes to the left, it moves downwards. Now look at the black line and the other brownish line, okay? The down. So when the eye goes down, when the eye goes up, the line goes up. When the eye goes down, the line goes down. Is that clear? This is all this technology called video dystechography is about. That's all. Okay. So whether it is the right eye or in the left eye, that is all that matters. For to see what is happening in the left eye, you see the lower part of the graph, blue line. Okay. Clear? This is all this is about. Now I want you to note some patterns here. So the pattern number one is eye in the center, no movement. Eye line, the red line in the center, no movement. Eye in the right, no movement. So line goes up and becomes flat. Eye down, no movement. Eye left, no movement. The line goes down and becomes flat. Is that okay? So that is the position of the eye, what happens. So now if the eye is in the center and still oscillating, you will get this. If eye goes to the left and still oscillating, you get this. If eye goes to the right and still oscillating, you get this. You got it? Center, oscillating. Okay, you saw this? So what is happening here is, I'll just take you to that position of the graph, the last one. I just stopped. Can you see here? In the mid gaze, in the left gaze, in the right gaze, in the mid gaze. Basically, how do you know where the gaze was? This position, vertical position. I was in the center, I was on the left,
eye was on the right. This level tells where the eye was. This is the horizontal level. Is that okay? If it was the same in the black line, it would have been center, down and up. That's all. Now, in that position, what movement it is making, you will come to know by looking at the pattern now. So now you know overall the orientation. Overall, what does this mean? What this means? Overall, this belongs to? This belongs to? Within this region, top belongs to right. Right of right eye. Left of right eye, which is nasal. Right eye nasal part, right eye temporal side. Right eye central side. Clear? In the left eye, the same. Central part, left part. Is that clear? All of you? Super. Now, we need to now recognize how to recognize. I was telling nystagmus. Very simple. First thing is nystagmus वहाँ है कि नहीं है. First question is nystagmus है कि नहीं है वहाँ. How do you know that in that particular region nystagmus था कि नहीं था, है कि नहीं? Does it look like a tooth of a saw? Sawtooth pattern दिखा? Nystagmus. If you see like a sawtooth, it's a nystagmus. Sawtooth नहीं है, वो nystagmus pattern नहीं है. This is all not nystagmus. Is that okay? Clear sawtooth pattern suggests nystagmus. Clear? Here, this device is called COG. It is not VNG. It is the next level. That is COG. Can you see it? When this nystagmus can you see a spontaneous shading, gray shade? Can you see a gray shade? Can you see a gray shade? Can you see a gray shade? That is, the system is telling you, these are all our improvements that we are introducing. System is telling you, yahan sir hil raha, head was moving. Therefore, this is physiological nystagmus. Don't give much importance to this. This is very important to differentiate and especially prevent misdiagnosis in BPPVs. This also tells the same thing. It is gray shading. It is physiological. We are doing this. This is happening because we are recording the head movement. This is the head movement. Head movement is showing as a mountain plot. There is a mountain, there is a mountain. These mountains, peaks in the mountains mean that there was a head movement of that velocity at that particular point of time. So that is a mountain plot. This is our innovation. Okay, this is totally our innovation. Okay. Eventually, through all of you, this will start coming in the publications. What is a mountain plot?
Sir,
okay.
Is that also nystagmus?
Which one, sir? That's a nystagmus. Yes, that's a nystagmus. Right? Between nystagmus. That's again physiological. Gray shaded. It's gray shaded, so it is. Now I will tell you why that was a nystagmus. So first was how to recognize a camel, how to recognize a lion. That thing you show the image. Sawtooth pattern है तो nystagmus है. Now why it is a nystagmus? Nystagmus is oscillation of the eye right and left. Eye slowly goes to one side, pushed by the vestibular system. Suddenly it goes to the other side, again pushed to the other side by the saccadic system. There are 5 ocular motor systems. Pursuit system, vergence system, optokinetic system. We have the vestibular system or the vestibulo-ocular system, and then the Chakkar system. Nystagmus is a combination of vestibular and Chakkar system. When the vestibule starts to push the eye to one side, there is another set of neurons which are measuring this thing and getting charge, which after some time just release the clutch. And it will tell, no, now the vestibular drive can no longer happen. Because otherwise, eyes will go and get locked in one corner. Because the vestibules push and take them and lock them in one corner. It cannot happen. It has to come back to the inside. At that time, clutch release mechanism happens, and at that time, the saccades fire the eye to the opposite side. Again, recontinuing the vestibular phase. Is that okay? Now coming to why is that a nystagmus? So we'll do that. So now, look at my eyes. I'll move the eyes slowly right and left. Is that okay? Slowly right, slowly to the left, slowly to the right. How is the slant of the slide?
There's a smooth slant and more flatter slant. See, I go slowly. Okay, I was also following the graph, so I started going up also. I do it a little different. Okay. I do it a little different. I'll hold on to something. Slowly. Did you see them going up? Now I'll move them fast. How was the line? This is more steeper. So now do you know a steep line is faster than a flatter line? So the steepness of the line tells whether the phase is slow or fast. Is that okay? More steeper, the less. What is it? Why is it so? It is like writing English from left to right. All the Indian languages we write from left to right. That is the convention. Okay. It is not like Hebrew or Arabic where they write from left to right. Okay, from right to left. This is from left to right. This is the convention that is followed. So now what is happening here when we are writing? This is time axis. If it goes in the time axis very fast, that means very steep. That means it has taken less time. If it is taking so much time, that means it has taken more time. So it is less steep. That is how you differentiate between fast and slow. Now we will go back to the nystagmus that we recorded before. Shall we go there? We had sets of nystagmuses here. I'll expand this. Okay. I've expanded that. I will do the vertical component to make it easy for you. Now just see. Can you see here? This line, from here it is starting. We are writing from left to right. Is that right? From here starts and it goes like this. It is going down or up? Down. Down means for the right eye. What does it mean? Down means? It is moving to the left. This one is? Right. It means moving to the right. Which is more steep? Right. Towards the right is more steep. All of us are together? Yes. So this means? Right. That's all. If I replace this red color with a black color, it means? Vertical. Upbeating. That's all it is. There is no enigma here. Half an hour, that's all. And then we are overloading graph mere ko nahi banta hai and all of those things. And we are doing. That's all this is. Okay. Right beating, left beating, up beating, down beating. Definitely, there are neurologists here. They will tell me this is more straightforward than EEG. Correct? That's all. This is definitely more straightforward. Right beating hai, left beating hai. That's all. Here you tell me what beating nystagmus is here. Left beating hai. Okay. We sample these things at 100 samples per second. Okay. This is like very advanced systems. Okay. This is called a digital plot, which means exactly if we take, I am taking 100 samples, I am showing those 100 samples per second. All of these things. When you are taking a photo, a car is moving, if you start clicking tuck, 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 with your phone, with your camera, tuck, 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 click. And if you see, if the car was moving slow, the immediate one after the other pictures will be close together. Is that correct? The car is moving fast. If you take one photo, by the time you take the next photo, it has moved farther. Correct? Yes or no? Here you can see the sampled dots. 1, 2, 3, 4, 5, 6, 7, 8. It's almost become like a straight line. Here can you see the dots are separated out? I will expand further. I will only show this part. Can you see? The dots are close, but fast phase dots are far away. So the eye was moving very fast at that particular. This is called a digital plot. Okay, this is called a digital plot. Okay, these are all our innovations. Okay, which we are doing so that it will make life easy. Second thing is this is also we make claims, but claims have to be backed up with actual data and value. Correct? No. So 100 samples per second means, see from 137 second to 138 second, if you see, if you count the number of dots, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. If I go up to there, I will count 100 dots. In 1 second, I am taking 100 snapshots of the eye, real snapshots of the eye. That is why we are able to see this accurate, okay? Nobody does that, okay? Then, when you look at the video, you can again reconfirm that. Okay, so you can see this, the video that is exactly what we did. So you can see all the things. The best part is, you see whatever my eye was doing. I just go to the last part where we demonstrated the eye movement. I did the head movement. Now, just see this. And this is when I started doing the head movement. Can you see the right beating stimulus? In the other gaze again right beating stimulus. In this gaze again right beating stimulus. Did you see that? Wonderful. Okay. And the left beating stimulus. Did you see that? All these things. The beauty of this one is, because it is 100 samples per second, when you actually slow motion it, you don't feel like you're actually slow motion. It looks like a real video. Is that right? This is slow motion. But the smoothness, this is the advantage of recording at 100 samples per second. Is that okay? So nobody can miss these mistakes. And see the quality of the video. Okay, don't you love the quality of this video? The eye video, the head video, and all of these things. This is true high quality recording. Okay, like HD quality recording of the eye. Okay, lots of thought process. For us, I want my country to be known for the best technology. It is not about, I'm not looking at any competition, that, this, and all of those things. No. Okay, I am only bothered about my country should be known for the best technology. And whoever supports me in this part of, okay, in this endeavor, you are supporting. Okay, that is right. That is why I have that much of thankfulness for people, especially the new buyers who first supported me. There are people who didn't want a device. When I first started off 10 years ago, there are people who did not even need a device. They bought it after 1 year, 1.5 years, 2 years, they started using it. But they wanted to buy it because I was doing something different. Okay, like that. Stay hungry, stay foolish. We have remained that, but then we were going on making our country proud with this kind of technology. And there are so much more than this. So thank you all, thank you so much. With that, then there are so many other features, but then I just thought that we will just show how to interpret the graph. All of you are comfortable right beating, left beating? That's it. There are so many other things. There's a positional test, there's a pupillometry protocol, there are mistake bus, calorics, clinical chair rotation, positional test, all of these things. Okay? Fine. So many things are there. Sachar's pursuit, optoparenting, all these things. These can be part of a different course or whatever it is we can do in detail. Okay? Like this. There's something called pupillometry, neurologists are there, so maybe one more minute if Prateek permits, the show of pupillometry. Is that okay? There is so many things are there. Apparent pupillary response is there. I'll just do the light reflex, okay? Stimulus right light. Let's start. Allow my pupils to dilate. You can start. Yeah. Pupillary right reflex, right eye, left eye, anyone eye. Start. Started? Yes. Yeah. Can you see now pupil became small? It became small? He is doing left eye. It became small. Okay? That's it. So 3 times. Okay? So 3 times he gave the stimulus to the left eye. This blue shading is the stimulus for the left eye. And the stimulus was for the left eye. The graph is looking like that because I have gone to the digital graph. But that's okay. So you can see the graph going down means pupil is becoming smaller. Okay? The pupil is becoming smaller. And you can see exact latency also. This is the time at which the light was flashed. This is the amount of latency. Like that, we can come to know what is the thing. Any apparent pupillary defect, there are so many defects. APD is there, left reflex is there, accommodation reflex, Hippus protocol, everything is recorded. And you can replay and see also. And of course, you can see the latency, time for constriction, time for dilatation, everything is calculated here. And then if you want to play back and see how the pupillary response is there, you can see the playback also. You will know when exactly the light came. It comes, okay, the light symbol comes there. Can you see that on the left side? Light, and then that is the time. So you can play, then you can play this in slow motion and see. So it's a beautiful neurological tool also. That is, how does the light show up? I'll show you here. Can you see here? When you see the goggle here, Just switch on the light. Can you see a light inside? Can you see a light inside? It shows up in the flap. Can you see this? This is moon principle. You know what? Moon doesn't have its own light. Is there a light? Can you see the light? Is there a light? Can you see the light? What we are doing is we want to make it safe for the patient somehow. So we don't want to keep an LED here and increase the number of electrical contacts, open electrical contacts from here and then put them. So what we done is very simple. Okay, what we have done here is, this is ENT endoscope principle. Put a light rod and then turn. Okay. We had to use fiber optic before, but we changed that to more of a rod principle, Hopkins rod type of this. So it takes light from here and it reflects and puts it from this. Light is coming from. Even the care that we take to make the glass that we put here, you can see the glass here. This is sapphire glass, the same glass that goes into iPhone cameras. Okay. It costs money, but it's okay. Because I want my country to be known for the best. That's it. And we started using fabric instead of all the foam and all these things and all the silicone. The reason again is, this is the new. 1 year ago, 1.5 years ago, in my own company, they were telling fabric is that is not this thing. People are using a lot of things. Why you are using fabric? Now, I can show them the advanced headphones, including the iPod Max, which has fabric. Now, suddenly my team realized, oh, you are far advanced. You are thinking of fabric. 2 saal pehle fabric soch raha hai. It is good. It feels very good, very soft on the patient. It can throw it away and use new. So that was an introduction. So many things are there. So if you are thinking of these things, it is okay. So that is a study. Then one important principle that I wanted to demonstrate before going to the thing. So the thing that we need to keep in mind, okay, is this. So if you are doing a big sulfite test on the right side, okay, just imagine, okay, I am doing a big sulfite test. Now what happens here is, if you do this, I am not marking that. Okay. So when I do this, can you see? Can you see any nystagmus?
Yes, sir. Yes.
Can you see any nystagmus?
Yes.
Can you see any nystagmus? If this video is sent to somebody without the head, will it be diagnosed as right posterior canal BPPV?
Yes.
Will it not be diagnosed as right posterior canal BPPV? Now our system is make sure that these all grayed out so that you don't see that, okay? It's all grayed out so that you don't see that this thing. Next thing is, okay, it's all, that area is grayed out. You can see the upbeating nystagmus here? You can see the downbeating nystagmus here? These are all during the per position. So you know, gray zone mein hai, ignore that. Okay. Other thing is, you look at the video also. If you cover this head video and tell, you will think that it is actually BPPV. But because the head video is there, सर जब मूवमेंट हो रहा था, सर का मूवमेंट जब हो रहा था, तब आ रहा है वो मिस्टेक्स. इसीलिए वो फिजियोलॉजिकल. This is why it is so important not to go only by the video. Okay, it's so important not to go only by the video. You saw that? So beautiful. Upbeating nystagmus. Somebody doesn't have a BPPV case to present, you can record. Okay, but you should see the head animation. And the head animation is contextual. Okay, if it is, can you see the downbeating? Physiological downbeating. Isn't that a joy to see that quality of videos? Should, when we have Zeiss microscope, who will operate with Bell microscope? Okay, thank you all. Thank you so much. Okay. Now we'll go for the hands-on of the.
So I need a subject.
Second, go back to the supine position. Okay, this is the third position. Next, go back to left lateral position. Then come back to supine position. Test is over.
So my question is, like, when the patient usually come to us, what I do is I take the head back and I do it by my hands. So should I do it by torso or should I
No,
do
it's
it
okay.
by
But I prefer with the torso to eliminate any remote possibility of a vascular cause or migrainous cause causing this problem. Not common, but I prefer the full torso.
Okay, full torso.
I prefer the full torso, but you can do it with just the wrist. Okay, fine. So now, this terminology now. The first one when she lie down is S1, supine 1. When she came back from the right to that position, supine 2. When she came back to that position, this is supine 3. If all the three positions shows the same direction of nystagmus, it is cupular pathology. In canal pathology, in one of the supine positions, it will be different from the other two supine positions. Because there are only three. Two have to be one has to be the other. Okay, if one is different, only one is different. Is that okay? So that is all. It is all three same or one is different from the rest two. That is canal pathology. Clear? There only you can differentiate between canalolithiasis and cupular pathology. I am not saying the word cupulolithiasis. Cupular pathology, because in cupular pathology, there is a light cupula and there is a heavy cupula. Okay, cupulolithiasis and a light cupula. Now, when she turned to the right side, okay. This is called right lateral position. Is that correct? When in the right lateral position, if she has a right beating nystagmus, will it look like it is banging on the earth? Correct? So that is, but you don't call it geotropic at that stage. You call it right lateral, right beating nystagmus. Correct? No? Then when she goes to the other side, now there is a left beating nystagmus. Does it look like you are banging on the ground? Is that right? Left beating nystagmus. So these two things, right lateral right beating plus left lateral left beating, we use the term geotropic. Is that correct? To say and denote for the both together. This will be generally associated with the canalolithiasis, especially if the nystagmus in S1, S2 and S3, one of them is different. Is that clear? So far, the main difference is going to be here. When she turns from the right to the supine versus when she comes to from the left to the supine, the direction will definitely be different. That is canalolithiasis. Is that okay? Because it depends on where the debris is moving from, the direction is. Now, important concept here. When she turned to the right side, she got a nystagmus. When she turned to the left side, she got a nystagmus. Now, the question here is, how many of you think this is bilateral BPPV? So, दोनों तरफ है, तो भी bilateral है. Does anybody have a question like that? Nobody has a question like that? Or a question के बारे में अभी तक सोचा नहीं. Because what happens is, then in the beginning it used to be like, there are a lot of times I take olden published literature with a pinch of salt because all these concepts were not that clear. Bilateral BPPV is so common, you see some paper. So unilateral, it can cause BPPV on the right. And there are other people who are not never agreeing that bilateral BPPV. Horizontal canal BPPV हो सकता है. These also some people who are not agreeing. You are talking about short term, they are not ready to accept. Prateek had an argument with one of the international presenters. Oh, I am telling the छोड़ दो यार. He is not leaving that. Okay, एक बहस चला एक पार्लियामेंट जैसा 15 minutes तक चला. नहीं सर, I am telling you. And guy is not accepting. This guy is not allowing him that it is नहीं है. ठीक है, that horizontal canal BPPV होता है. He is telling वो नहीं होता है. Then next 2-3 साल में बाद वही दोबारा आके horizontal BPPV के बारे में बता के गया. So it is there.
Michael Fruit.
It's okay. That's okay.
Now, sir,
now,
that's the question.
Yes, sir.
Like whenever we are doing the
Yes.
beginning, you get nystagmus on right side.
Yes.
Down below.
Yeah.
But when you are doing on the opposite side,
Yeah.
you don't find it.
Yes.
So how do you correlate both of these conditions?
So you get on both sides versus you get only on one side. No problem. So the important concept here is unilateral afflictions can be bilaterally symptomatic. It just needs a debris flow. It just needs the lowest part in the canal to change. That's all. So if the person can have debris only in the right lateral canal, the person can have nystagmus because of right lateral canal on right lateral position also, on left lateral position also. So BPPV, bilateral symptomatization even in unilateral afflictions is a common behavior. Point taken? So you should never be confused कि दोनों तरफ आया इसलिए दोनों तरफ debris है. That is most important part. Number one. Second thing, what is this question? Sir's question is, one side only you are getting, other side you are not. Doesn't matter. It's a low debris, small amount of it. That's all. Okay. In the ampulopetal direction, it is crossing. Ampulofugal इतना छोटा, इतना कम है कि नहीं आता. Okay. The flow is slow.
Now another scenario. How now you do it on the one side, you get it. Do it on you do it on the opposite side, you get it. How you differentiate the diseases on the one side only and
Yes, that is
not bilateral?
That is the next part. Okay. So what happens here is, you see a very nice behavior here. There are 2-3 points here. If you get this side also, that side also, and the two are of unequal intensity. On the right side it is more right beating, on the left side it is left beating, but it is less intense. The highest intensity one is the affected side, that is because of the ampulopetal flow in horizontal canals, which is more stimulatory than the ampulofugal flow. Okay, so that is one. Now your next question will be agar dono taraf same. Okay, is that right? What was your next question? So the next one is, if right also and left also, if it is both are same, or how do you tell, in that case also, how do you tell whether it is bilateral affliction? Bilateral affliction, there is a beautiful thing here. The sit to supine position will show behavior, because the debris is moving from this side also, that side also, both of them. They cancel one another. In the sit to supine position, you will not get anything, but in the turning from one side to the other side, you always get. Okay. In the sit to supine, you will not get it. Okay, bilateral. This is the behavior in bilateral. Sit to supine, you will not get it. Bow and lean also, you may not get anything in bilateral. So that is the beauty in bilateral. But turning from right lateral to supine, from left lateral to supine, they are going to get. So this is one behavior in bilateral afflictions. Otherwise, though they are equal, the secondary localizing test of right side is affected, left side is affected, is a bow and lean test. So if the mistake was for geotropic, when you bow down, if it was right beating, then right side is affected. If you lean, if it was right beating, in apogeotropic, then if it was apogeotropic, what mistake was you get in the lean position? Okay, sir?
Sir, one more.
Yes, yes.
So in one patient, when I was doing my clear suppose I turn the head only,
yes,
there was no nystagmus.
Yeah.
If I turn the whole body,
okay,
then there was nystagmus.
Maybe it was a delayed onset, or it was a second time or the same time?
Same time.
Same time. There are some things. See, when you saw Pratishta's photo of that particular thing, there are a lot of curvatures and all of this thing, which we need to little more analyze and this thing. I have seen that, including to the extent that when I take the person to one lateral position, little bit, I do a little more than I get. I have got it when the nose goes down also. I have seen that also. When the nose goes down, I have seen it. I have also seen it when I bring it from the Dixalpine position to the horizontal position, it starts getting activated. That may have to do something with horizontal canal. We assume it as a nice tube in one plane. It is not a nice tube in one plane. It goes up like this, it comes like this, then it turns and it goes like that. So there are somewhere that we are guiding that particle around the curvatures. So that is possible. So it is the point, clinical point here is that you need to try some combinations if you are not getting it. Sir.
Sir, one thing. First, localizing, you said that if there is slow phase velocity is where the high is, that side is more.
Yeah.
Suppose both sides slow phase velocity is same. Then second is the bowling test. Would there be any correlation that if on the right side more beats are there as compared to left, would that be criteria?
That more beat side, so that will be in the sense, the longer beat sides will also be the side of the less intense nystagmus.
Okay.
The longer beat side will be the less intense nystagmus. The shorter duration one will have more. If you count the beats, maybe this will be more, but this will hit fast, and it will die down. Whereas the other side one, the other flow that is happening, this thing, that will be longer.
Longer, but we have a
slow phase velocity will be more like this. Instead of the nystagmus looking like this, it will look. and for a longer time. What we have observed is the low intensity nystagmus for some reason persists longer. The high intensity nystagmus, probably the brain finds it easier to suppress it fast. So it doesn't persist long. So don't go by the length of the nystagmus, but by the stroke slant. Okay. It looks like tuck, 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 and then stop. So always this question is there. So this comes like tuck, 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 and it stops. But it is in that part it is intense. On the other side it has long, it has. Which one to take as more intense? Take this side as the more intense. Yeah, this is.
Sir, one more question.
Yeah.
Sir, we are talking about the BNP. When we are seeing the eye movement, when we are doing in the clinical scenario, when the person is not available,
Doesn't matter.
And many times you are not able to identify the nystagmus, but the patient, when we are turning, patient complains that he or she is having some overtime. So, then how to identify?
Sitting up vertigo. Sitting up vertigo is short arm posterior. Posterior canal ka short arm. So symptomatically you have to make a diagnosis. You make a diagnosis of short arm and posterior. It's called sitting up vertigo. Okay. Question answered?
Dr. Srinivas, one question.
Second thing, yes sir. I'll just finish that.
Yeah, sure.
Second thing is, don't think that we cannot, if you don't have a device, I make a device, okay, I have an interest in selling the device. But don't think that if you don't have a device, you cannot record. Prateek demonstrated so well that there is nothing better than a phone. Okay, with another dedicated assistant who can be trained, who can take a video record. And all phones have a 120 FPS, 240 FPS, which means you can record in slow motion also on planes. The advantage of a graph is that to see a 2-minute video, you again need not replay for 2 minutes. The graph will show you. And you can just look at the graph one snapshot and you get where the mistake is. That is the biggest advantage. And then of course with the goggle, you will remove the fixation. But otherwise you can record. Okay sir? Yes sir.
So when you have a right lateral and a left lateral, what happens in central position? What has been your observation?
In the sense when you are going from right to left and left to right.
Right. When the person is not moving and is in the bang in the center, does the eye show any nystagmus?
Of course. That is what I was trying to tell. In the beginning I mentioned 3 things. Sit to supine, S1. Right lateral to supine, S2. Left lateral supine, S3. If in the 3 supine positions, S1, S2 and S3, nystagmus remains direction fixed in the 3 supine positions, it is a cupular weakness. If the nystagmus direction changes at least in one of these things, it is a canal weakness, which means there is going to be nystagmus. There is in the initial supine position, if you don't get a nystagmus, and you get very equal nystagmus on right lateral, left lateral, it is bilateral application.
Imperceptible nystagmus, like if you don't have a device and the nystagmus is imperceptible, the patient is complaining.
That is called subjective BPPV. That is called subjective BPPV, and again they get better with numbers. One good thing, at least the observation so far that I have made is, subjective BPPV is more common in the posterior canal than in the lateral. Okay, so if you get a subjective BPPV, treat it as a posterior canal. Okay, and when the nystagmus is so low, it will have been symptomatic on the side affected side. So use those 2 clues and use them. Okay. The most relaxed person. Volunteer. The idea of doing this way was, I just discussed with Prateek, to demonstrate how simple and how easy it is. This is all it is. So on the right lateral position, actually got a left beating nystagmus. It would have looked like you are throwing like this, water like this. Is that okay? Geotropic is like you are washing clothes like this. Apogeotropic is like you are throwing water. Is that correct? As if from this side you are playing that. From that side again you are throwing water. Is that right? So like that. So that is called on the right lateral left beating, on the left lateral right beating position. Is called apogeo. Is that okay? That is called apogeotropic. So now you know the that is called apogeotropic BPPV. In apogeotropic BPPV also the strong nystagmus, which side it beats, gives the canals involved. Which side it beats gives the canal involved. Previously there used to be one more rule. In apogeotropic, on the side lying to which you get less intense nystagmus, both are the same. Okay. Because if you are lying on the right side, if there is a left side involved, lying on the right side, you get a left beating nystagmus very strongly. On the left side, you get a right beating nystagmus low. Okay. Left low intensity. Left lying to the left, low intensity right beating. So left side is the affected side, less intense nystagmus. On the right side, you got strong left beating nystagmus. Left beating nystagmus is strong. So therefore, left side is affected, both being the same. Is that okay? So think simple, uncluttered brain, simple use. Unless you are supposed to give a DNB exam, you don't have to bother about all this. Just take clinical cue. Is that right? If you are going to give an exam, then you have to be ready for both explanations, explaining to the examiner all of these things. But nowadays examiners are asking vertigo questions. They are okay. So best is, and some people are using simply my name. कौन बताया कहाँ सीखा so Srinivas even if they are telling wrong also okay okay fine so now coming to maths you're not going to go down for this much relaxation little more you have to do put your legs on this side this is acute so it is all clear this test is clear so what is cupulolysis what is canalolysis how to identify you there's a third possibility. You get a geotropic pattern, but S1, S2, S3 is fixed. The moment I told S1 में, S2 and S3 में same nystagmus मिला, cupular pathology, cupular lithiasis. Cupular lithiasis में apogeotropic pattern मिला. लेकिन आपको S1, S2 and S3 में same nystagmus मिला. और right lateral में left beating, left lateral में right beating. इसका मतलब है जियोट्रोपिक पैटर्न हमें सिखाया गया था कि कैनालोलिथियासिस में होता है और यहाँ मैं आगे एक्स्ट्रा कंफ्यूज कर रहा हूँ कि S1, S2, S3 में सेम मिल रहा है तो कुपुलर पैथोलॉजी तो एक कैसे कुपुलर पैथोलॉजी है जिसमें जियोट्रोपिक पैटर्न इट इज कॉल्ड लाइट कुपुलर it is called light cupula it is very commonly associated with migraine it can also be an intermediate stage between cupulolithiasis conversion to canalolithiasis in between where the sludge dissolves in the endolymph making the endolymph heavier and the cupula lighter. Is that okay? I'm trying to practice my English. There are mistakes please. I was always afraid of speaking English because everything has a gender and we never were used to this is not new. The second part is we were never taught Hindi well down south, okay? Because it's always if somebody close here knows somebody in the Mantralaya who can tell people, tell them that textbooks should not be like a torture. You can give answers. Answers कोई नहीं देता. Textbook तो है. Textbook used to be there. There used to be questions, but there was never a code for answers. And nobody knew what was the correct answer. Had we knew what is the correct answer, we would have learned. And we never had enough people to tell who knew the correct answer, who was teaching us. Despite that, we have reached this part in learning this language. It's good, no? The only source of our authentic Hindi was Doordarshan News. Okay, so that is what. So now what happens? Dil ki baat ya dil ka baat? Dil is boy.
Dil is important, sir.
Dil is boy or girl?
It doesn't matter. Dil is important only.
You don't know. I don't know. I don't know. Why bother that? There was somebody from Rajasthan who tells me it is Dil Kaaba. Somebody from Lucknow tells me Dil Kiba. So these confusions were there. When that is there, somebody should teach better. Like that. So that's okay. Coming to. But reasonably good now. कभी एक दिन लाल किले से भी बात कर सकते हैं. So next thing is the Dick's arthritis. Is that okay? Go a little backwards. Turn your head to the right side. So now this is the first thing. Somebody is asked to turn to the right side, examiner or whatever. They turn it fully to one side. Okay, just 45 days. So little less. This is 45 days. This understanding is very important. Commonest mistake, including by big faculty in forums, big forums I see, is when the Dix-Alpine test is being demonstrated, the head is done.
Sir, can I?
Yes, sir.
I think before going to Dix-Alpine,
Yeah.
we should clear the lateral canal.
Therapy.
Therapy.
Sir, 5 minutes में diagnostic complete कर दूँगा. ठीक है sir? Then I will come to that. You want to go home? So Dix-Alpine test. Now this is the first step. Next step is put the head down. Not that way. This one. No. This again another confusion. Okay. So this. Is that okay? This is the first step. This is to make the debris move more towards the ampulla, so that when the test is done, it falls from a bigger height and you will get a higher positivity. Is that okay? Now go back, lie down. We'll take care of this. And put your head down. We'll take care of this. Don't worry. And this is enough. Go down. Put the head down. This. Is that okay? This has to be, at this point, somebody should support the head, otherwise neck pain will come. This is the next step. The half alpine position. This position you have to maintain for 60 seconds if you don't get the nystagmus. If you get the nystagmus, you record the nystagmus and then come out. But if you don't get the nystagmus, don't declare the test negative unless you really observe for 60 seconds, because a person who labels himself as a vertigo specialist, immediately board change हो जाएगा. Okay, that it is vertigo specialist. So when the board changes, and then the person comes, if you miss a diagnosis, for the person to get the diagnosis again, may take another 2 years. Because जो vertigo specialist है, वो पता है BPPV नहीं, so everybody will start thinking something else, and then working का और 2 साल के market. Then next thing is, next position is lift the head up to 30 degrees, to turn this. This is the half alpine position. If you don't do this, you will miss the oculolithiasis, especially small load oculolithiasis. Is that okay? The last one is sit up. Record here also. Is that fine? Is that good? Okay. So this is how we are going to do the Dix-Alpine. The last one is a straight head hanging. Most of the time it will not be required because the anterior canal will show up here. करना है तो सर सीधा रखिए. Then go down and keep the head down. That's it. Okay. That is you will get for anterior canal. These are the only things: lateral canal, posterior canal, and anterior canal. All the three. Now we will go with the therapeutic.
Sir, half Dix.
Half alpine. Yeah.
This is for basically.
Pupulolithiasis. For pupulolithiasis.
So sometimes when the anterior canal does not come up with DST, it comes only with hanging.
Sir?
Lot of times. Superior canal only comes up with hanging.
Yes.
Come with,
So we can do that. So if you don't get it, by then if you don't get it, then do it.
Currently, what last 1 year, what I'm getting more is superior canal BPPV as compared to posterior canal.
And also short arm.
And also short arm.
That means you are in a referral practice.
Yes, I'm in a.
That means Prateek has taught other people. Posterior canal. तो posterior canal feature हो रहा है. आपके पास institutional practice में सिर्फ हो. Yes.
Short arm canal which is posterior.
So when she goes down, she will not have much symptoms. When she comes up, even the half back also or sit up also, she gets the same upbeating instinct. Posterior canal में long arm, in the long arm posterior canal, when you go down, you get an upbeating instinct. When you bring the patient up, you get a downbeating instinct. Whereas in short arm, on sitting up, you will get an upbeating instinct. Because the debris on coming up pushes against the pupilla. Okay, you will get an upbeating instinct. Okay.
Sir, whether we should stop after one side Dix-Alpine or we should perform on the other side?
My preference is to perform right side. First do metal pregnant, do right also, do left also. But depends on the practice. Like the busy OPD and all of those things. Then do, get it, finish it, and then do a check maneuver and send the patient. Okay, it's like, okay. It's always like how busy you are.
So check maneuver after how much time?
So you can do the check maneuver immediately also, but I prefer waiting for 20 minutes. Yeah. In 20 minutes in the head, nose pitched forward position, the debris will move to the anterior part of the utricle, where it is more likely to be packed. Anterior part of the utricular sac is flatter posterior, flatter anteroposterior. It goes there, it gets into the pocket. It's good to push it into the pocket. Okay, so that it stays there, it doesn't come back into the. Is that okay? Fine. So next thing is, the next other part of anterior part of the utricle is the closed end of the canals open there. Okay. So with the closed end of the canals, that is anterior canal, lateral canal, anterior ends are closed ends. They are closed with the cupula. So from there, getting into the canals is difficult. It will not get. Only from the back end they get it. Okay. So, fine. So this much is now treatment. Correct. Treatment of lateral canal, treatment of posterior canal, and treatment of anterior. Here. That's all. So this one will be good. So now simplest maneuver is barbecue roll. So barbecue roll maneuver is something like this. Can I close it? My neck and start showing. Yes. We can draw diagrams. You all have energy for another 1 hour, or you want to finish this off in 15 to 15 pack up. What is it? Huh?
We have to leave here.
Oh, no, there are 2 ways of doing this. We go thorough. We have a solid understanding of what is happening with each maneuver.
Yes.
So which means we stay here till 8 o'clock.
Yes. 8 o'clock is okay.
Okay. Abhi time kitna hai? 7:10. 50. That means 9 o'clock. Yes, I was thinking it is 6 o'clock. Okay. That is fine. Or we just go show the maneuvers. Show the maneuvers. Okay, show the maneuvers. Then we'll just show the maneuvers. How to treat right, how to treat left, and give the mnemonics. Is that okay? And then we'll have one more ChakkarCon version 2, where we show all these things. Otherwise, I invite all of you one more time, February 5, 6, 7, 8. It's going to be a gala, super. And most important, you know what? Say this, sir. Abstracts, basically. Make papers check. Sir, abstracts. Please send abstracts. We want more people to be on the stage and presenting. Please share papers. Is that okay? Share. Everybody. Whoever is doing some kind of work here, send abstracts. We are looking for abstracts, okay? We are getting a lot of registrations. We are close to 300 registrations. But abstracts, 4, 5. We want more abstracts, okay? We don't want to show like we are, like, we want to put up the speakers based on the abstracts that are. That is more important. So please send more and more abstracts, okay? Otherwise it is like we are choosing, like, okay, it's not like that. This time we want to choose the speakers based on the abstracts. Please send, okay? Whoever is doing some vertigo work, or whoever wants to do, please do that, okay? Next. Whatever it is, if the broad topic you want any guidance on the abstracts also, we will give you. What topics are the broad distribution of all of this? Okay. BPPV was on, migraine is one, okay, miniaris is one, all these different gross topics are there. Any of these things we can. Fine. Even difficult cases can be one. Now we will just show you the, so please, how to register? IB, integrated balance FORUM.IN, integrated balance forum.in. Is that okay? You all remember? There everything is there. Clear. Now, for, you are okay with being the volunteer? Sure? No problem? Good. Video consent here. There is. Come to the center. Now let us see that she has a canalolithiasis, that is the geotropic, lateral canal. She can canalolithiasis, geotropic of the lateral canal. And let us see that she has it on the right ear. Is that okay? Which side? Right ear. What was the canalolithiasis? What was the canalolithiasis? Which ear? Right ear. Is that correct? So, what type? Canalolithiasis is geotropic type. Geotropic stands for G, correct? The maneuver we are going to choose is going to start with G, Buffon. It involves falling to the good side. Falling to the good side. So how do you do this? She just holds like this and then she falls to the good side. Is that okay? Then the last step is the nose is turned towards the ground. Is that clear? And then from that position, she should see also. And then she sits. Is that okay? हम तो गॉगल पहना के करते हैं, चश्मा पहन के तो कर सकते हैं. Okay.
So,
You're able to see?
my question is,
Yes.
whether it should go to Singh or we can go for Bhakti?
Both are okay. Both are okay. Okay. So Buffon is little violent, but little higher success rate than Barbecue because of the accelerations, decelerations involved. So okay, clear so far?
Sir, each position for
30 seconds. 30 seconds, more than 30 seconds, more than that. So this was geotropic. Agar right side ka apogeotropic, the right side is apogeotropic. Then what do you do? Then you do the same thing. Then the maneuver chosen is apogeotropic apiani maneuver. So and then for there she falls to the affected side. And then from there, if she sees, the nose goes apogee. Is that clear? Is that fine? That's it. Clear? G, 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 G. A. So is it not a coincidence? It's not a coincidence. There is a divine plan. It's not a coincidence.
How long do you
30 seconds. We had a freedom fighter named Sanguli Raya. He was born on, he was killed by the British in a fight, okay, near Belgaum. It's a place called Acute. The born date and death date I may have mixed, but say he was born on January 26th and he died on August 15th, or it may be opposite. About a century later, when we get independence, we get our Independence Day is on one of his birthday or death, and then our Republic Day is one of his death. These are not coincidences. There is much more than coincidence. This G, A matching is not like that. Only a surgeon, when you are operating inside, when the planes open up, you feel like the design was for one day a surgeon to come and operate and it feels like that. ये design ऐसा बना है कोई आके एक दिन surgery. When we are designing our equipment, we have a concept called design for manufacture, design for service. It is not service. It is not enough that you manufacture it well. If something goes wrong, you should be able to easily fix that problem. You change one chip, you just do. There is something called being able to open it up and put it back together. Apple products are not designed for service. Okay. We have to make a product which is designed for manufacture plus service. That is the human body has been designed. In fact, all biology has been designed for service. When one day surgeon can come. Very plain stuff. The next thing is about the posterior canal. So this is lateral canal. The other maneuver for lateral canal are kinder maneuvers. Kinder maneuvers are maneuvers where you just do a barbecue roll. How do you do the barbecue roll for geotropic? Let's see. The right side is affected for barbecue roll. You go down like this, right down. You can have one step where you turn to this side for a brief while. Actually, the debris goes in the opposite direction. It sometimes helps in unplugging it if it is plugged into one place. Then it comes like this. Then she turns to the other side, left lateral position. Okay? Then finally she goes nose down. Okay. Prone position. That's it. This is the last step. In the prone position step is when from the last step, last part of the lateral canal, it falls down. The lateral canal anatomy is, it comes in me, it comes like this, it goes like this, it goes like this. It's like this. So in the prone position, from the last part, it falls inside. It is not a steep, it's a hyperactive. Right? So in this position, from this place, She can sit up, but not everybody are able to sit up from here. So you can turn little more and then you can sit up. Or you can sit up on all fours from here. This is the barbecue roll.
So in barbecue roll, on the when we ask the patient to turn on the same other side, would there be an nystagmus at that time?
By then you should not get. If it is there, then you have to again one more time do the McLeod method.
Sir, in all, we have to put the nose down for 20 minutes. After all the maneuvers.
After that, keeping the nose down for 20 minutes is excellent after any maneuver. Okay. So the next thing is, after this, if it was apogeotropic, in geotropic, the W was on the back part, from here only you can turn. If it was apogeotropic, she first has to lie down on the affected side. Is that okay? So let's this side. Or just sit down. Lie down on this side. On the affected, no, go down, go down. So you start from the affected side, not from the supine position. That's the only difference between barbecue and Zuma. Zuma is the other maneuver for apogeo. Okay, other than Appiani maneuver. Appiani always has to be followed by Buffoni because Appiani converts it into geotropic and Appiani does not cure it. Whereas Zuma cures it. You start here, then you go like this, go supine position, supine position. Then you go to the lateral position. Fine. Now, here it is in the last but one part of the lateral canal. Now this has to go into the utricle, which means nose should come down. In the classic barbecue roll, to make the nose go down, what we were doing? We were making her prone. Zuma had a different idea. What this guy did, he's a very old man. Okay. To do this, now in this position you put the head down like this, and now make her sit. When she sits up, legs down and sit up. From that position when she sits up, the nose is down. Is that okay? This is Zuma. Is that clear? This is how the Zuma is done. That's all. So these are, with that we complete lateral canal BPPV. Now we need to do posterior canal. Is that correct? Come to here. Yeah, little more. Lift the right hand up. Right posterior canal. Turn to the other side. And lie down. Lie down here. Lie down. Go down fully. Go down fully. With the head like this. And go off. Go down. Is that okay? This is the first part of Simon. This is the hyper Simon. Is that okay? Keep the legs down. And then go down like this. Is that okay? This is the second part of Simon's maneuver. And then she sits up. What is most often mistaken or done wrong is, when she goes down like this, they go like this. When she goes down like, they go up like this. This is very common mistake patients do. So no, it goes like this, and then keep the nose like that only, and she goes like this. She seems to be liking it. I can't see the face expression, but behind, but I feel that she's liking it. See? From behind I could see the expression. Correct. Okay, fine. So this is like, so this is the Simon maneuver. Then the other maneuver is, you're okay, still okay? Keep the legs still. Reconfirming video all again. So come here. Back. Now next one is the play maneuver for the legs. Okay, same thing. Down like this. Go down like this. Give as much as extension as is feasible. Okay? And then next step is 60 seconds here. Next step is head goes like this. The common mistake is they overdo this. See, I will tell you this, what is mistaken. If you do this much of turning, you don't get extension. So she is okay, but most people they cannot. But 45 degrees it goes down. 45 degrees you turn like this. Next is, who all has been doing regularly? Yeah. Now I will tell you a tip. Put the hand down like this. Now life becomes super simple. Okay? Roll over. Roll over. Put snap. Even if that falls also, by then I can hold it. Okay? Is that okay? Down. What is different from the usual Eplis is, the hand has gone down. So rolling over is super simple. Otherwise you have to roll on the hand is very difficult. Okay? Is that fine? Okay. Put the legs down. Sit down. That's it. Clear? Okay?
Rolling, so what about the head has to be extended?
Head has to at that time become flexed.
Okay.
Okay.
The one to be kept extended, which was earlier.
No, by the time it becomes flexed. And then?
So easier for her.
Of course.
You get the patients who are quite steady.
Even heavy also it's easy. Pick up somebody whom you want from there. Don't pick up straight. Okay. It's easy. Come straight. You want to demonstrate. Don't please. Come up, come back. Yeah, come to this side. You're taking two, keep the hand down. That's it. Okay? Now the head goes straight. Then sit down. Okay?
Sir, in cases of patient who has anterior spinal ligament
This time you have not taught-
fixation or something,
Yeah.
in which
Difficult.
very difficult.
Very difficult, sir.
In those cases, patient do have nystagmus or do have the positive Dixon pipe, but might not be doing till 45 degree, may have only 20 or 30 degree head movement, and when they lie down even straight, they have classical posterior canal.
बट आपको वो जो पोजीशन चाहिए था वो नहीं मिल रहा है तो इसीलिए सक्सेस नहीं हो रहा है करेक्ट नो दैट इज द क्वेश्चन
In those cases, even if we are getting 30 degree angulation or extension, we are only getting 10 degree, not 30 degree as is required. If we do at least in that altered position, would that be a successful maneuver or not? Because I have done it, patient improves.
So first thing is if the patient improve, that is the biggest thing. Patient improve, that was enough for us.
But that's what I'm saying. Then how does the physiologically we explain that
Higher it is,
that is
higher it
45
is,
degree.
we are talking about getting the 90 degree drop. So when you go to that extent, you get a tube which is more vertical, which gives a drop. Short of the drop, there are multiple levels of slant, which may be good enough in a lot of cases.
In cases where small
Simon also is true. Simon also is true.
this type of patients,
But the best thing that I do in this patient, if I don't get success, is I take the patient to the minor OT table. Minor OT has a reverse pedal and just take the foot end up. You can do it. That overall earth orientation, earth relation to earth, the canal orientation you get. So you saw Simon Conwell, you saw Acute. The only thing that we are supposed to see is another variety that is short arm posterior canal. For that, what is
one thing? This time you have not showed to jump.
Everybody says train hai,
I thought.
So what you do here is the final last thing after the this thing is to Pradeep was telling. In fact, best success for all these cases is before the maneuver. There is Prateek. He is doing some key arrangement, sublocate key. So like this. Before, look at God and jump and land on the heels. What happens?
Before maneuver.
Before the maneuver. What will happen is, from here, from this part, the posterior canal, the debris becomes little loose and it just comes out.
Head extended.
Head extended,
Jump.
go on and land on the heels. Yeah. But not everybody can do this because landing on the heels is
I normally practice, ask them to go up on the toe and then jump on
Jump
them,
on them.
rather than jumping up completely.
That is a beautiful suggestion. Okay.
Because that will give more stability.
Which is better. Safety modification. ये paper होना है. So your abstract is that. Okay.
Because I normally ask them to do this and
So,
then
what you do in the next step is look, when everything is over, say thanks to God, and then again close. So first pray, finally say thanks.
No, I mean, when we are asking patient to come
After-
down, I ask patient to jump, that's it.
Yes.
And then I ask the patient to keep standing in that head down position for 1 minute.
Yes.
So
What
after
I
that
do-
also you want me to ask patient to jump once more.
You can do one more if possible.
Once more jumping.
Or once to, we keep making the jump 2-3 times, okay? It's not like one jump. So jump first, jump it. Thanks jump, prayer jump, thanks jump. Just to remember, okay, look up, seek blessings. Finally, thanks.
normally tell the patient how I Let's suppose I'm
Yeah.
the patient, I hold the patient.
I make them judge.
Hold the patient.
You also
then, no. As the patient will do this, suppose I'm
Yes.
the patient, then the person is holding up and then down. Yeah. So I hold the patient so that
Holding we are also doing. Holding we are also doing. Okay, sir. But we are making them jump. Your modification feels more safe. And it feels equally good. Great. Okay. Super. Holding we are also doing. But this is good. Yeah, this is good. This is good. So this type and this type. Great. Then they presented in Bali Society, jumping the oh, animation band, jumping the So this is about the other thing is this thing is most commonly used is short arm posterior canal, which turns out to be becoming more and more common. Dr. Pradeep Porwal is seeing that more commonly. You are telling that it is seeing more commonly. I am feeling that it is seeing more commonly. So what we do? Rosalie. Now kneel down. Punishment. Okay. Now put your head down. This is the maneuver for short arm posterior. Is that okay? Then from here. Is that okay? 30 times. Okay? And then only problem is a lot of elderly people with knee problems are not able to do this. For that, what we do? Lie down.
At the end of
And it goes lie down on your stomach. Come forward. Down. And this one. This is easier. This is prone, pitch and yaw. Okay, this is called prone, pitch and yaw. Yeah. These are the two maneuvers for anything. All these things happen, then you do prone, pitch and yaw after apply maneuver. Nowadays we do apply maneuver, do prone, pitch and yaw, apply, prone, pitch and yaw, and then we send the patient. All these things we are doing. Next thing is, this covers most of the conditions of posterior.
pupillithiasis.
Pupillithiasis immotalis. Only thing some people suggest that you use a vibrator. There is a vibrator by name Actonia in APQNIA that is available in Decathlon. If you are searching for vibrator on Amazon, gives wrong results. So in Decathlon there is something called Actonia. Okay. White color one with the three. I searched once on Amazon, whichever website I start visiting from that time onwards, I started getting all kinds of suggestions. Then we had to delete cookies and all of those things to stop those suggestions from there. So now what is happening? Next thing is to do the anterior canal. For anterior canal, again kneel down. This is Prateek's maneuver. Come down. Yes. So first the hairline between the forehead and the hairline. That part has to touch the surface of it. So this is the forehead and the hairline when you add a hair. That is very important. So that is the point. Next thing is put the vertex down. So 30 seconds there, and the vertex down for about 45 seconds. Then up, sit down. Then look upwards for 15 seconds and then look downwards. That's it. The maneuver is over. Okay. So this is the Prateek's maneuver. TB maneuver. Okay. That's fine.
For superior canal, we have a more simpler one.
Yeah.
You just take the at the end of the table. You take the patient down by 60 degrees and then up by 60 degrees. That is more simple, I guess.
Which one?
Yeah.
That works wonderful. But if it doesn't work, you need another solution. No?
That time we will call people. For that time, we need to call people.
This is easy.
That is gravity dependent. This is liberating.
This is more liberating because there are more faster movements and all of those things. This works. And also giving that, from at that position, even if you want to give 2-3 jerks also, it is possible from this. Okay. The last one is Jacobino maneuver. Then I will show you the quickly. on your back. For some reason, we have started working in Bangalore. Okay. You don't even do a COVID. Come back. Now you go down like this and do steps. Is that okay? Next step is the chin touches the. Then it sits up. This is your Epovino. Is that okay? Epovino did Epovino maneuver on me. Give a demonstration. Where is the photograph? How do you put this up? No. Surajit has taken it. Not this one. Epovino did the maneuver on me. So fine. So this is about anti. Quick liberate usually. Okay, quick brisk sometimes. This is effective when Apple is not working generally. Is from this position you skip the second step and directly go to the other step. Okay, right. And then sit down.
This brisk Apple is
for there is a this thing called apogeo-tropic posterior canal, which I have not taken, or I'm not fully convinced that when I come across as but it is apogeo-tropic posterior canal. So for that it works. Here, when a is not helping, there was one Indian railways employee for that he made a paper on this and those were the dealings. Anantu, everybody was there. Anantu used to go to that Indian railways, there was not appealing. So that day we did this one. For the opposite topic was there. So that's why movie is there, but I'm not really convinced about that. So it works. But quick liberatory works in some way. So with that, we can go for dinner. Have questions? Otherwise, I've covered it. If we are up to 10 o'clock, I will draw how the debris goes in each step. And that one. That would be Vedas. We did only the
4 days workshop.
No, that is not a workshop. That is a lot of talks, different talks. A nice program is coming up.
Pre-conference we will have the workshops. A group photo.
जो बचा